Optic disc edema, papilledema. It is a passive, non-inflammatory edema of the optic disc due to increased intracranial pressure being transmitted to the optic nerves via the cerebrospinal fluid in the subarachnoid space. Etiology and associations of papilledema. Prelaminar, local and systemic diseases as malignant hypertension, central retinal vein occlusion, anterior ischemic optic neuropathy, decreased intraocular pressure, ocular hypotony, as in ocular fistula following surgery or trauma. Ocular hypotony lowers prelaminar pressure and slows exoplasmic transport. Collagen diseases like systemic lupus erythematosus, sarcoidosis, giant cell arthritis, and polyarthritis nodosa. Hematologic disorders as anemia, polycythemia vera, leukemia, macroglobulinemia. Cardiopulmonary diseases as emphysema, congenital heart defects, and cystic fibrosis. Retrolaminar, caused by increased intraorbital pressure or increased intracranial pressure, as in space-occupying lesion, inflammation, meningitis, encephalitis or abscess, trauma with associated hemorrhage, aneurysm, pseudotumor cerebri, internal hydrocephalus, and hypercapnia. Pathogenesis. Normally, axonal transport along ganglion cell axons that forms the optic nerve occurs in two ways. Orthograde, from cell body to lateral geniculate nucleus. This is the slow component, 1 to 4 mm per day. Retrograde, from geniculate nucleus to cell body. This is the fast component, 400 mm per day. Lamina cribrosa separates optic nerve into a prelaminar and intraocular component. Normally, intraocular pressure, prelaminar pressure, exceeds cerebrospinal fluid pressure. Elevating cerebrospinal fluid pressure abolishes the differential gradient between intraocular and intracranial pressures. Accumulation of exoplasmic flow, especially slow orthograde component at the lamina cribrosa, leading to disc swelling and nerve fiber layer opacification. Microscopic picture of papilledema. Optic nerve head changes. Nerve head swelling, narrowing of physiological cup, increase in disc diameter with indistinct blurred margins, enlarged blind spot, elevation of the disc and mushrooming of the nerve head into the vitreous, opacification of nerve elements, and deflection of the vessels at disc margins. Retinal changes. Lateral displacement of peripapillary retina, photoreceptors, buckling, folds of outer retina, Patton's concentric folds. Venous congestion and tortuosity with normal arteries. Flame-shaped hemorrhages at disc margins. Shallow peripapillary serous exudates. Cytoid body formation over the surface and at disc margins. Anterior bowing of lamina cribrosa. Late changes. Ascending and descending degeneration. Shunt vessels. Secondary optic atrophy within 6 to 9 months. It is to be noted that papilledema does not develop in primary optic atrophy or in high myopic optic discs. Differential diagnosis of papilledema. Pseudopapilledema. Lesions inducing an elevation of the nerve head mimicking papilledema, as occurring in papillitic optic neuritis, pseudotumor cerebri, persistent Bergmeister papilla, hyperopia, metallated nerve fibers, epipapillary hamartomas and tumors.